welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today we have Rachel Bishop, who is a PGY2 critical care resident at the University of Rochester Medical Center Strong Memorial Hospital, and she'll be presenting on the Journal Club Adenosine versus fixed-dose intravenous bolus Diltiazem on reversing supraventricular tachycardia in the emergency department.
All right. Hi, everybody. Thank you for the introduction. So just as a little bit of background, supraventricular tachycardia is a term that's used to describe several types of neurocomplex tachyarrhythmias, and it accounts for 50,000 emergency department visits annually in the United States. It typically arises from an atrial or atrioventricular nodal tissue. However, it can be difficult to distinguish different SVT subtypes in the emergency department, and this is generally limited by timing and resources and the potential hemodynamic instability of the patient. And as a result, these arrhythmias are commonly classified as an AV nodal reentrant tachycardia and are managed as such. I do want to talk a little bit about some guideline recommendations that are out there surrounding supraventricular tachycardia management, or I will be referring to as SVT for the remainder of this presentation. There's the 2015 American Heart Association guidelines, and there's also the European guidelines from 2019. Both recommend vagal maneuvers and or adenosine as first line, followed by an IV non-dihydropyridine calcium channel blocker, such as Diltiazem or verapamil, or an IV beta blocker. And if a patient is hemodynamically unstable, we would do synchronized cardioversion instead of medication management. I do want to talk about the two medications that I will be discussing today in the Journal Club. The first is adenosine, which binds to the alpha-1 receptor, ultimately inhibiting L-type calcium channels, opening of potassium channels, and hyperpolarizing the cell. The typical dosing is 6 milligram dose bolus times 1 after about 1 to 2 minutes. If there is no cessation of SVT and return to sinus rhythm, we would do another 12 milligram dose. And then you can also repeat a 12 milligram or 18 milligram dose times 1 as well. From previous studies, the conversion rates have been ranging from 69 to 91.4%. However, there has been an estimate of about 57% of cases of those that received adenosine do relapse into SVT within 5 minutes of receiving it. The PK has a rapid onset for adenosine and a short duration of action of about 10 to 30 seconds. And there are some concerning side effects that can occur with adenosine, such as chest pain, flushing, sense of impending doom, which leads to seeking other options for patients if adenosine is not available or if there are concerns about these adverse effects. So Diltiazem is a second agent that we could use. As I said previously, it's a non-dihydropyridine calcium channel blocker, and there could be an IV bolus dose of 0.25 mg per kg times 1, followed by a secondary dose of 0.35 mg per kg if there's no cessation of SVT, or there could be an infusion that starts, and that infusion can be increased to about 15 milligrams per hour. The conversion rates, although there are not many studies looking at Diltiazem specifically, more so with verapamil, but the studies that we currently have show that there's a 96.3 to 100% conversion rate out of SVT with Diltiazem. The onset is a bit longer, of about 3 minutes, and the duration is 3 hours. And one concerning side effect that will be discussed in this presentation is hypotension, but it also can worsen heart failure and bradycardia. And I do want to mention that in terms of cost, which is a concern about determining what agent we may use over another in some institutions, adenosine is typically more expensive compared to Diltiazem. I do want to discuss a few trials that have looked at comparing adenosine versus a calcium channel blocker or Diltiazem specifically. So the first study was the LIM trial in 2009. It was prospective retrospective cohort study that compared adenosine versus a slow infusion of verapamil or Diltiazem. So this is a bit different than what we're going to be seeing in the study I will be talking about. There was about 206 patients in this, and conversion rates were higher in the calcium channel blocker group compared to the adenosine group. In a meta-analysis that came out in 2017, they looked at adenosine versus verapamil and diltiazem, and verapamil was the primary calcium channel blocker used in this trial. It was a larger study that included 7 trials, but they found no difference in the number of people that converted to sinus rhythm. So ultimately, the purpose of this study was to look at the adenosine or diltiazem use in a urban ED. It was a multi-center cohort study by Lee and colleagues. And the reason why they wanted to do this was to determine if there's other agents that we could use in case there's availability concerns or cost concerns or adverse effect concerns with adenosine. So as I had said, the purpose was to evaluate the utilization and efficacy of fixed dose IV bolus diltiazem compared to adenosine for supraventricular tachycardia in the ED. It was a retrospective multi-center cohort study that was from January 1st of 2019 to January 16th, 2022, and records were obtained using ICD-10 codes that were for SVT. Patients were included if they were adults that presented with a stable SVT and received bolus adenosine or diltiazem, and they were excluded if there was inadequate documentation in the EMR. Looking at initial group comparison of the study groups, so there was the initial group and there were subgroup analysis. The first group compared those that received adenosine first and compared that to those that received diltiazem first. In other words, only patients in the adenosine first group received adenosine and they could have received multiple doses. And similarly with diltiazem, they only received diltiazem. They defined treatment success, which was the primary outcome of achieving conversion to sinus rhythm within 30 minutes with either agent as monotherapy. When they did the subgroup analysis, they looked at different scenarios in which patients received multi-agent therapy. The first scenario would be that they received adenosine first, followed by diltiazem. The second scenario would have been diltiazem and then subsequently received adenosine if they did not convert out of sinus rhythm. And third, they received one of the agents and then received an additional agent that was not adenosine or diltiazem. So primarily, I'm going to be focusing on the diltiazem success group because there were no patients that started with diltiazem and then received adenosine. Diltiazem success group were those that received adenosine but did not convert to sinus rhythm until they were given diltiazem. Looking at the primary outcomes, as I had said previously, it was successful conversion to sinus rhythm within 30 minutes of a bolus administration. And secondary outcomes included the length of time that it took to convert to sinus rhythm, and then the response doses that it took to achieve that conversion. And then for statistical analysis, they used Fisher's exact test for baseline characteristics and categorical variables, a t-test for continuous variables, a Wilcoxon rank sum test for the time to sinus rhythm variable, and p of less than 0.05 was considered statistically significant. This is not an all-inclusive list of all of the baseline characteristics, but I am going to just touch on a few of these. So there were a total of 344 patients that were included in the primary analysis, which again was those that only received adenosine as monotherapy and those that received diltiazem as monotherapy. I will say that there was no flowchart or number that discussed how many patients were excluded from this study, which I thought was interesting. But looking at this, we can see that the diltiazem group had 34 patients, adenosine first group had 310 patients. There were older age patients in the diltiazem group. Most patients were white, and overall the body mass index was about the same. But I do want to point out that pulse was a little bit higher initially in the adenosine first group compared to the diltiazem first group. And then looking here at some of the comorbidities, so we could see that there were a higher percentage of patients in the diltiazem first group that had hypertension as a comorbidity. Overall, the systolic blood pressure initially and diastolic blood pressure initially were similar between the groups. Going back up to cancer, there was a higher percentage of patients in the diltiazem group that had cancer compared to the adenosine group. Now getting into the primary outcomes, so I have included a few screenshots of different charts that were in the study. This first one here on the y-axis is the percentage of patients that achieved a successful conversion, which is our primary outcome, and the time elapsed over minutes. The blue is the adenosine first group, and the red is diltiazem first group. So looking at the success rate at 30 minutes, we could see that adenosine had 207 patients compared to diltiazem, which had 28 patients that had a success rate at 30 minutes of converting to sinus rhythm. This was not statistically significant. However, the percentage is numerically higher in the diltiazem group, which is something that I just wanted to make note of. And then the median time to successful conversion was higher in the adenosine group compared to the diltiazem group, 3 minutes versus 6 minutes. And this was statistically significant. And I think that this makes sense based off of what we know about the onset of action of adenosine. There's a quicker onset, rapid, compared to diltiazem, which takes about 3 minutes to start working. And then going into looking at this chart, which represents the dose amounts that were administered for the monotherapy initial group. So again, we had 207 patients in the adenosine group. The average was, or the median was 12 milligrams. And we can see on the graph here on the left that most patients had to receive a higher dose than 6 milligrams to achieve sinus conversion. With diltiazem, of the 28 patients, the median dose that was received was 15 milligrams. I will point out that it did not, in the baseline characteristics, discuss what the weights of these patients were. So we don't really know, is this like a lower dose compared to what we see in the guidelines? We're not really sure, but just something that I thought was interesting. And this is getting into the subgroup analysis. So here on the left-hand side, we can see all the different scenarios that could have occurred during this study. Patients received adenosine and failed adenosine and subsequently received diltiazem. I've highlighted that box in red. We can see that 18 patients had this happen, and 51% of patients who failed adenosine received this rescue diltiazem. Of those patients, these 18 patients were successfully converted out of sinus rhythm after receiving diltiazem. There was an additional subgroup analysis that also looked at patients who converted from SVT to AFib and A-flutter after they received their initial treatment. So I just wanted to talk about that a little bit here as well. So there were a total of 24 patients that were in this subgroup. And I will say for the subgroup analysis, in order to account for these patients, they did include conversion to another rate, such as AFib or A-flutter, into the success or failure of the treatment. So these 24 patients, out of them, 22 or 92% developed AFib or A-flutter after they received adenosine. And 13 of those patients were successfully converted to sinus rhythm and were able to be discharged. And 10 of these 13 patients were managed with diltiazem. And there were no hypotensive episodes that were recorded, which is a concern when we're thinking about giving diltiazem to these patients. So going into discussion of the study, we saw that fixed dose bolus diltiazem monotherapy demonstrated similar conversion rates to adenosine. However, there was a numerically percentage higher difference in the diltiazem group, but it was not statistically significant. I will also say that the groups were largely imbalanced with the amount of patients in each group. So one thing I would want to see for future studies is doing a power calculation to determine what percentage of patients we would need to achieve this primary outcome, where it would be significant and have power. Secondarily, adenosine had a faster rate to conversion than diltiazem. And as I had said previously, most patients required a 12 or 18 milligram dose of adenosine for conversion. There were some deviation from the AHA guidelines that were identified. One of them was that there was a large percentage of patients that only received the 6 milligram dose of adenosine at the end of the 30-minute time interval. So as we know, we should be redosing after about 1 to 2 minutes after an unsuccessful conversion with the 6 milligram dose. So I thought that was interesting. And then diltiazem successfully converted about 35% of adenosine refractory cases of those that had AFib after receiving their initial dose of adenosine. Going into some strengths and limitations. So being a multi-center real-world analysis of SVT management in the emergency department is a strength. It shows what is happening in real life in institutions. And there's also validity in the data collection. So I didn't mention this previously, but there were 2 people that abstracted data for each of the patients. I did want to point out some limitations, however. So being a retrospective study, we really don't know why one agent was chosen over another. Perhaps there was a larger group of patients for adenosine because that is recommended first line per guidelines, but I would have been curious to see if there were specific comorbidities that were looked at to determine why diltiazem may have been chosen as monotherapy or chosen first over adenosine. There were imbalanced sample sizes and study groups, as I had mentioned. Another thing is statistical tests. So we really don't know the distribution of data for this study. We don't know if it was parametric or not, which makes it difficult to really be able to interpret the statistical tests. Similarly, I would have liked to see some secondary analysis looking at, any confounding factors that could have contributed to these results. One other thing that was also not mentioned in this study, but was mentioned in previous studies, was if patients had their arm raised before receiving adenosine. I think that could have been important to help with understanding the results a little bit more. Timing of all medication administrations were not tracked. So if patients received multiple doses from the time that they started to the end of the 30-minute interval, we don't really know how far apart these medications were giving, although we do know that there were some deviations from the AHI guidelines of what doses were given by the end of the 30-minute interval. And finally, weight was not recorded as a characteristic in the beginning of the study, so we really don't know if these patients received an adequate dose of the diltiazem. Going into my final conclusions, so diltiazem and adenosine had similar conversion rates, and diltiazem effectively rescued cases that did not respond to adenosine. And this does contribute to growing literature that diltiazem may be as efficacious as adenosine with additional therapeutic potential, such as those that did convert to AFib or aflutter after an episode of SVT. My personal conclusions are that diltiazem may be a considerable alternative for SVT treatment, but I do think that there needs to be some larger multi-center studies that are more balanced and perhaps have a little bit more statistical analysis to determine the external validity of these results. Here are my references, and thank you. I'm happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.